Hello everyone. Today I will discuss about lingual thyroid, which is a developmental disturbance. So coming to introduction, what is lingual thyroid and how it developed? During the 3rd to 4th week of fetal life, the thyroid gland begins as an epithelial proliferation in the floor of the pharyngeal gut. So during the development or during the embryogenesis, around 3rd week to 4th week, there is a development of or epithelial proliferation of thyroid gland. By the 7th week, this thyroid bud normally descends into the neck to its final resting position anterior to the trachea and larynx. This is the site where this descending thyroid bud invaginates later becomes the foramen cecum. That foramen cecum, which is located at the junction between the anterior 2/3 and posterior 1/3 of the tongue in the midline. So if the primitive gland doesn't descend normally, then there is an ectopic thyroid tissue may be found between the foramen cecum and the epiglottis. That will lead to lingual thyroid or swelling in the middle third of the tongue. Of all the ectopic thyroid, 90% are found in this region. Then clinical features based on autopsy studies, small asymptomatic remnants of thyroid tissue can be discovered on the posterior dorsal part of the tongue. In about 10% of both men and women showed lingual thyroid tissue. Clinically evident or symptomatic lingual thyroids are much less common and 4 to 7 times more frequent in females because of hormonal imbalance. In symptomatic patients, symptoms most often develop during puberty, adolescence, pregnancy or menopause. Lingual thyroid may range from small asymptomatic nodular lesions to a large mass that can block the airway. And most common clinical symptoms like dysphagia, dysphonia and dyspnea. Dysphagia, that means difficulty in swallowing. Dysphonia, that is disorders of voice. Dyspnea is shortness of breath. The lingual thyroid may be manifested clinically as a nodular mass in or near the base of the tongue in the vicinity of foramen cecum, but not always in the midline. This mass is more commonly appear as a deeply seated or deeply situated lesion and tends to have a smooth surface rather than a superficial exophytic lesion. These lingual thyroid are deeply situated and having smooth surface. The surface is smooth. In some cases, it may appear as vascular and it is appear more red color, while in others the color of the mucosa is not atypical. This is a picture of nodular mass of the posterior dorsal midline of the tongue in a 4-year-old girl. The size of the lesion is 2 to 3 cm in diameter. The chief symptoms may vary, but the presenting complaint is dysphagia, dysphonia, dyspnea, hemorrhage with pain, or a feeling of tightness or fullness in the throat. Many authors state that lingual thyroid enlargement is a secondary phenomenon compensating for thyroid hypofunction. Diagnosis is best established by thyroid scan using iodine isotopes or technetium 99M, CT, that is computed tomography, and MRI, magnetic resonance imaging, can be helpful in reducing the size and extent of the lesion. Biopsy of thyroid is often avoided because the mass may represent the patient's only functioning thyroid tissue. In some patients, incisional biopsy may be needed to confirm the diagnosis or to rule out malignant changes. In the picture, it is a thyroid scan of the same patient, that clinical picture of a 4-year-old girl. The scan shows localization, that is central dark zone. You can see the central part is more dark. That is the localization of iodine isotope in the tongue mass and minimal uptake in the neck. Histopathological features. The benign lingual thyroid nodules may present a variety of microscopic patterns, but in the majority of the cases, they resemble either normal thyroid tissue or thyroid tissue of an embryonal or fetal type. In some some cases, the nodules exhibit colloid degeneration or goiter. Great care must be taken to distinguish these lesions from lesions derived from accessory salivary glands in the same location. Both the lingual thyroid and these salivary glands may give rise to adenomas or adenocarcinomas in the tongue. Then the treatment plan for lingual thyroid. There is no treatment plan except periodic follow-up is required for patients with asymptomatic lingual thyroids. In symptomatic patients, suppressive therapy with supplemental thyroid hormone often can reduce the size of the lesion. Some authors advise that this treatment should be tried in asymptomatic patients to prevent the possible subsequent enlargement. If symptomatic patients, suppressive therapy with supplemental thyroid hormone can reduce the size of the lesion. If hormone therapy doesn't eliminate the symptoms in symptomatic patients, surgical removal or ablation with radioactive iodine 131 can be performed. And if the mass is surgically excised, autotransplantation to another body site can be attempted to maintain the functional thyroid tissue and to prevent the hypothyroidism. Some cases or any rare examples, carcinomas arising in lingual thyroids have been reported. And in malignancy develops in about 1% of identified cases. Some authors also have advocated that prophylactic excision of lingual thyroids in men older than 30 years of age. So these are all about the lingual thyroid. I hope you like this video. So please like and subscribe to this channel. Thank you so much.